So we do have it live stream, but I value people coming here. So we're not taking any questions. We're just going to answer questions that are here, and you and us will be here. That's just an observer, because it just threw me off last time, and nothing like face to face, right? Cool.
Awesome. I get started?
Awesome. Yes.
Cool.
Ready? Cool.
Awesome. Well, thank you guys for coming. I think I've met all of you, but I'm Dr. Sarah Weinstein. You can call me Sass if you want. So we are going to be talking about the shoulder today. So lots of people have issues with the shoulder. I'm going to be talking common treatments to these issues, and then obviously how I kind of work hand in hand with Jana and the Fluid Physio team and physical therapists so that we can really optimize your guys' outcomes and get you back to what you guys love doing the most, whether that is archery, basketball, softball, picking up your kids, whatever you have. So obviously, like, stop me at any time. This is really informal. Ask questions, jump in, whatnot. Anything you want to mention first?
Yeah. So I wanted to say that if there's anything in particular, anybody has like specific shoulder things that you want to ask, then maybe you can let us know now, and then make sure that we can catch it, or you can later on ask questions also. But tell us. Yes.
So I have an issue where I guess I sleep on my shoulder.
Okay.
I'm not sure. It's like, when you're doing things on a so I like to sleep on my
while
side.
you're sleeping on your side.
Yeah, so
okay.
For that issue, I would have soreness where too high for a while I start to feel it. So I'm not sure.
Cool.
Or just
all right. Awesome. Thank you, Christina. So we're going to keep in mind that we have a young female that has pain when they're sleeping and maybe sleeping, so that we're going to go through some of this stuff. That definitely helps me, because then I'll be like, oh yeah, I'm going to make sure I mention that. Cool. And we go from there. And if you still are like, well, I don't know, then we might say, guess what? We have a deal for you.
Awesome. So let's get started. First thing I want to talk about is just some basic anatomy, so you guys kind of understand the shoulder, what the joint is, everything surrounding.
Dr. Sarsi Weinstein, core sports
medicine,
sports medicine, and lifestyle medicine.
That's right.
In Princeton, New Jersey.
Yes. Yes.
And your practice is you're still baby practice.
Pretty fresh.
But you've been around for a while. Tell us a little bit about that.
Yeah. So I started my career, big ortho group. I started off at Rothman Orthopedics. I was there for 3 years, went to another practice, started their medical side of PT, OT, chiro, and acupuncture. I was there for a little bit, and then I just decided I want to start my own practice and kind of treat patients the way that they deserve, give them the time they deserve, and kind of how I think that they should be treated, and have the time to do all of that. So I opened my practice in November in Princeton Junction. It's called Core Sports Medicine and Lifestyle Medicine, because I love the core, and there's just so much good stuff about that. All starts with the core. So I've been open since like mid-November, and just moving forward, and it's been super exciting and really just so rewarding, kind of treating patients how I really envisioned when I went into medicine. I do a combination of non-surgical sports medicine, which I'll kind of talk about, and then I do lifestyle medicine as well, which is a separate specialty, but obviously goes hand in hand with sports medicine.
Cool. Thank you.
Yes,
now,
you're welcome.
Shoulder.
Cool.
You guys know.
Yes.
Us.
So shoulder anatomy. So shoulder, super mobile joint, right? That allows us to throw, that allows us to, do all the activities we want to, moves all around, right? But with that mobility comes vulnerability, right? And we can be more prone to injury because of how mobile it is. This type of joint is actually called the ball and socket joint, because essentially the humerus, the arm bone, fits into the socket of the scapula. And so it allows it to move all around and have more mobility. But again, that means that we need a lot of stuff surrounding that to provide stability. The hip joint is also a ball and socket joint, but a little bit less mobility than the shoulder. So the kind of the biggest thing that obviously people think about when they hear shoulder is the rotator cuff, right? And so people are like, is that, just one thing? What is the rotator cuff, right? I hear this term all the time. The rotator cuff is actually comprised of 4 muscles that surround and protect the shoulder to provide that stability for this ball and socket joint so that our shoulder is not just consistently popping out of place. The 4 muscles that comprise the rotator cuff are the subscapularis, which is a muscle that's in front, the supraspinatus, which is on top, and then there's 2 muscles in the back called infraspinatus and teres minor. All of these have different functions and work in different ways to give us the strength that our shoulder needs. And so the supraspinatus, which is the one that's on top, you can see it. Yeah, you can see it here. Mm-hmm. That's probably a better one.
Yeah, this one's funky because you can't move it, but this one's technically under here.
So it's up there. It comes up here. Supra meaning above, spinatus means spine of the scapula. So again, the shoulder blade in the back, there's like this little ridge here, right along here. And so the muscle above it is supraspinatus and the one below is infraspinatus. That muscle, the supraspinatus, most common injured rotator cuff muscle. That's the one that allows us to come up overhead, also reach back behind us, okay? The infraspinatus and the teres minor, both of these are in the back, help us to externally rotate the shoulder. And then subscapularis in the front helps us to internally rotate the shoulder or bring our shoulder in. Again, so they all obviously have different functions to allow us to do different things and move in multiple different motions. Obviously, there's a lot of stuff going on with those, so a lot of things can also go wrong. Also in that area, we have the biceps. So a lot of people kind of forget, about the biceps. The biceps, I don't know if it's better on this. Not really.
Well, you can just sort of you can see the long head of biceps here.
Yeah. So biceps, bi meaning 2. There's 2 heads of the biceps. The long head comes up and essentially comes and inserts into the rotator cuff interval. So people who have rotator cuff pain often will feel pain over the long head biceps as well, which is kind of right in the front here. So they can really kind of be tied in together. The short head is over here, but that long head is really what can kind of get caught up with other rotator cuff manifestations. The other thing that we want to think about with the shoulder is obviously our neck is really close to our shoulder, right? And so neck and shoulder really are very interconnected. And so sometimes somebody comes in with shoulder pain, it's really coming from the neck. Sometimes people come with neck pain, really coming from the shoulder, but they work hand in hand, and the shoulder blade and like the scapular muscles, they all work together to, again, protect both of those areas. And John will kind of go into how posture and, stabilization of that shoulder blade play such critical roles in both the shoulder and the neck. That erases, right?
Yeah.
Okay. So that is kind of like your basic anatomy. Obviously, bone-wise, you've got the humerus, you've got your scapula, which is your shoulder blade. You've got your collarbone up here. Where your clavicle meets the shoulder blade is called the AC joint, so the acromioclavicular joint, which is another joint, and then you've got your main shoulder joint here. So those are kind of like the biggest areas, and the rotator cuff is probably by far the most common issue that I see. There's several issues that can stem from the rotator cuff, everything from more of a tendonitis or inflammation of the tendon and an impingement picture to, partial tears, full tears, and whatnot. Do you want me to go through those quickly, or do you want to you want me to go through those?
Yep, I was thinking you can go through that, and then I can go into the other.
Perfect.
Posture, scapular control,
awesome,
acromial space.
Cool. Mm-hmm. So one big thing that I see is both tendonitis. So that's essentially inflammation of the tendon. Tendon is where the muscle attaches to the bone. Okay. So most common, again, it's that supraspinatus muscle that can get acutely inflamed, whether you go out and play catch with your kids or you have a fall on it. That can acutely inflame the tendon, but you can also have issues that are more chronic in nature. So just overuse injuries, if you've played baseball your entire life, or, you have a job that is chronically putting you at risk, then we see kind of more chronic tendon changes as well. When somebody has rotator cuff issues, they come into the office, Most common complaint, again, is going to be shoulder pain, pain with reaching overhead, sometimes reaching back behind, and also laying on the affected side at night. So really, really common for the rotator cuff to hurt when you're laying on that side. It's also pretty common to have pain that radiates into the outside of the shoulder. So a lot of people are like, is this my deltoid? You know, what's going on here? This is a really common rotator cuff pain that you feel on the outside. If it's more on the front here, again, that's sometimes more biceps, but it doesn't often travel all the way down, no numbness, tingling. If it travels, you know, past here, I'm thinking sometimes it's more coming from the neck, especially if there's more of a numbness, tingling. But those are the most common things that I see. And then obviously when I'm doing an exam, that overhead movement, when I'm trying to really stress that tendon, is very painful for people, as well as kind of bringing them across like this, which is more what we call an impingement sign. So that's kind of something really common I see. Impingement is another term that we kind of talk about, and that essentially means that kind of goes along with the bursitis as well. And sitting on top of that supraspinatus muscle that I talked about is a bursa. Not there.
I don't think you're gonna get it.
Yeah. Anyways, there's a bursa, which is a fluid-filled sac that helps to prevent friction and just provide better movement in the area. That, with an acute injury or with chronic injury, can get inflamed and can get almost pinched as well when doing certain motions. So again, that motion and bringing across are going to further stress that. If somebody is really weak on exam and I'm doing some strength testing and, you know, they can't even hold up their arm and it just drops down, I'm more concerned that there might be something more like a tear, whether that's, you know, a partial tear or a complete tear. And history kind of goes along with that as well, based on, you know, what they came in with if there was an injury. So that's why history and doing the exam is super important to kind of tease out what the issue is here, because that will depend on how I treat it as well. With a lot of these, really the vast majority of these, the treatment is non-operative, right? So like the vast majority of the time, these people are not going to need surgery, at least not in the beginning. And there's a lot of stuff that we can do between myself and physical therapy that will get patients back to their activity, back to what they're doing, and hopefully prevent this from happening again in the future. So when I see someone, say they come in for this rotator cuff bursitis or tendonitis or impingement, and I am not concerned that they've got, you know, partial tear or full tear, because strength is pretty good, but it's definitely painful, we start talking about the conservative treatment options. So first thing I do, sometimes some anti-inflammatories, depending on how bad it is, will just kind of help to take the edge off. So, you know, Advil, ibuprofen, and I don't do it for a long time. I typically do like 5 to 7 days worth, just to take the edge off and get you moving, and usually into physical therapy, doing a home exercise program, strengthening that rotator cuff, the postural muscles, which Jonna will go more into. If you're in such severe pain that like you can't lift your arm up and, you know, you're like physical therapy, like I don't even know how I'm going to do physical therapy because it's so painful, or you're literally not sleeping at night because it's so painful and it's keeping you up, that's when I talk about things like doing an injection at that time. And that's typically a cortisone injection into that bursa that I was talking about. And I do all my injections ultrasound guided just to make sure that I'm getting into the right spot. So that's something that I can just do in the office if I think that, you know, you won't be able to optimize physical therapy enough, so that if we do that, it'll calm things down pretty quick, and then we'll get you moving again in physical therapy. I think that's all I had to mention really about rotator cuff issues. Obviously, if I'm more concerned that there's like partial tear, like full tear, where you have that weakness, I'm getting more advanced imaging, usually like an MRI, which will further show kind of the integrity of those tendons or muscles. Because if you're a candidate for surgery and, you know, this was an acute injury, I will be sending you to a surgeon to make sure that that is followed up appropriately. And if you need surgery, then that's done. But again, we can treat most rotator cuff issues non-operatively between, you know, myself, physical therapy, using different modalities that we have. So Jonna can talk about kind of what she targets.
I wanted to touch base, and maybe you can talk a little bit about that, because we had one of the persons that was going to come. she had a history of falls. And so within a year, and all for dumb reasons, like over a branch and the kids, the grandchildren's toys, a lot of like what we call foosh, the fall on the outstretched arms. So a lot of that impact, and how, you know, any other injuries that you may see, and how that relates to the labrum or some in that sort of
like the common injuries that cause these issues. Yeah, so obviously like the more acute injuries are going to be your falls. So whether that is, somebody who trips and falls over something, lands this way. We also see it, you know, skiing, snowboarding, skateboarding, anything where you're going and you can fall onto that shoulder. That can affect both rotator cuff, that can affect the AC joint as well. Obviously, you know, playing sports, and, you know, volleyball players, throwing athletes, they are at the biggest risk for that chronic overuse degeneration. So with time, we will see, you know, changes to the tendon that reflect that this has been going on for a while. So we see that a lot in our throwing athletes, but not only, you know, sports and athletes, but occupations that put you at risk where you're constantly working overhead, right? So, you know, mechanics who are working overhead, people who are painting or like carpentry, people who are using their shoulders all the time, like even
hairdressers.
Yeah, so hairdressers is huge, right? Your arms are like
your dental hygienist.
Yeah, so that's another one for big tennis elbow too. But like these people who are doing these repetitive movements for work, and like it's not like they can be like, oh, I'm just not going to go to work today, right? Like it's just fixing, you know, and modifying to get around that because this is their job and they, you know, need to make money. So. But those occupations kind of pose a risk too. So you've got kind of the acute injuries from a fall or, you know, injury during athletics. You've got the chronic overusers.
Pickleball,
yeah. And the occupation. So those are kind of like the big categories, obviously, that we see. And then any prior injury that you've had, even like when you were younger, you can obviously build up scar tissue. You can have, you know, issues with that as well, whether that's mobility problems and whatnot. But that can obviously compound over time, and if you've been compensating, we see a lot of issues that kind of arise later on too.
Yeah. And one of the things that I wanted to mention is, you know, you mentioned that subacromial space. And so that subacromial space is so important. There are so many, it's such a small space, right? So in this model, you can see it's just sort of super tiny. And one of the things that why it's so critical, it's because posture has such a big deal with it. So if we see it, so the humerus is kind of like a little hammer shape, right? So if our posture is nice and tall, right, the shoulder blade basically sits right over the ribs. So if we have good, decent posture, this little subacromial space is nice and open, right? Because then we reach our arm and our arm reaches, except we have good posture. It's okay. But what happens over time, and especially to that dominant side, which is like, I'm right-handed, the mouse, the phone. When I had my kids, I would put them here and I would do stuff with them so they could just hold them. That's the hand I open doors with. And over time, our dominant side, the majority of people, it tends to come down and sort of tip forward. So instead of being like this, it sort of tips like this, right? I could have a perfectly level spine and still have a little bit of this happening, right? So on top of that, I could also sort of like do this because gravity and time just take over. And this little bit, now not only do I have my dominant tendency of the right side, but I also have my spine doing a little bit of this. So what happens to that little hammerhead is that, oh, now do you see how it's a much smaller area? And so simply because it's a much smaller area, those rotator cuff tendons, especially the one that Dr. Sassi mentioned, that supraspinatus that travels through this little thing, it kind of just rubs over the roof of that subacromial space, which is another piece, the acromion process of the shoulder blade, and it just rubs and rubs. And what happens to that? Imagine a rope starts to fray, right? So that's where your degenerative type tears end up happening. It's because you have this roof and little movements, it just keeps going and going and just sort of. And so one day you just kept playing pickleball and it just sort of like little piece of it happened, little piece of it tore, right? And so having different layers of it, you can tear. So you have sort of the fibers, right? And you can do sort of a partial thickness tear, right? So this is kind of how I measure it. Or you can have a partial full thickness tear, but you still have some attachment. So you can still strengthen what's attached. You can add a little bit of medication to calm down the inflammation and calm everything down and strengthen what's still attached. But the most important part with posture is we have to address that super important subacromial space. And so posture, and the other part is going to be muscular endurance, because if we just talk about, oh, I got to be up nice and tall, and then we don't realize, oh, I got to be up and nice and tall, we have to build up that muscular endurance. So the next part, now going right into posture. Oh, the other thing was endurance. Okay. The other part, was motor control, right? Because one thing is that I know where it's at, but then so many people have no idea that they have all this movement, right? So they end up sort of doing and using a lot of lifting from here. So it's retraining the shoulder blade muscles, and they're all around. We'll start with, so here's our spine. We have the rhomboids are right here. And then the levator scapula, that one goes up to our neck. And then we're going to go to the traps. The traps are shown on this side, but I'm actually going to draw over it. So we have the upper traps, the middle traps, and the lower traps. And you can see them here, right? That's from the back and the top. Then we go from the front. We have, so that when Dr. Sassy was talking about the pec minor, well, in that little spot, it's this little spot of your shoulder blade actually that peeks through, and that's where your pec minor is. This one attaches right into your ribs, right? And that's where, when we're so used to coming forward, that one gets really tight. And the last one, and one of the most important ones that people don't even realize, is the serratus anterior. That one, I have it drawn here, but it's literally underneath the shoulder blade. It attaches right underneath the edge of the shoulder blade, and from the edge of that shoulder blade, and so in this view, we can kind of see it peak there, but then we can see it here because it attaches under the shoulder blades and it comes right around the ribs. And so all of those muscles act like a steering wheel. And so over time, if this pec minor gets really tight, it tips it forward. We start to compensate because then the mechanics shift. And so now your upper trap and levator start to do a lot of stuff and stabilize. That's not their job. And the serratus gets weak. So the shoulder, the bottom side of the shoulder kind of tips forward. And it just creates this dysfunctional movement. And so one of the things those are the shoulder blade muscles. But again, then we mentioned posture, right? So I want everybody to sit at the edge of your chair. I don't tell people this much, but just sort of slump. Sometimes I do, right? Especially when we want to see like before and after. Because sometimes you don't even realize you're slumping or slouching. That's a bad word. Okay, so then just sort of see what it's like to lift your arms, what it feels like, and look how high they can go, right? And then we're gonna bring your shoulders back and notice what happens now when you can bring, and you can see like, oh, are you guys ready? Do the wave. So that alone, we can actually address some of the shoulder pain working only with motor control and posture, just because then we allow those tissues that are inflamed to just be free and have more space. So that alone can make huge improvements. And so when you go see Dr. Sassy and you get an injection, or any doctor, and you get an injection, it's like, oh, but I got an injection and it felt better for like a week or two, and then it came back.
Then treat the root cause.
Because you didn't actually address the cause of it, right? You can have sort of traumatic things that set it off, right? Oh my God, I had to study for a really long test coming up for grad school, and I had to study, and I stayed up, and then I took the test, and then I went home and I slept for 12 hours. Coming. Christina's going to start grad school soon. So, and then I was like, oh my God, I woke up. So you could have a traumatic or an event that set things off, but you could have had pre-existing weaknesses or postural issues that just sort of like, oh, but this wasn't there before. How come the injection didn't take care of it? It just came back, right? And that's that motor control. And so oftentimes, not only do we work on motor control, right? It's like teaching that scapula that, oh, you have to stay here and move. And both shoulder blades have to do it together. But also you might have weaknesses as a result of just being here, weaknesses through the rotator cuff. One of the things that I see with people with that have had a rotator cuff tendinopathy is that their rotator cuff is actually really weak, especially on their dominant side. It's like, well, this is your dominant side. It should be strong. They only became weak simply because of that postural mobility, the postural issues, and then just the muscles don't work as they should. So rotator cuff doesn't do the job that they have to because they have the deltoid or the biceps to overcompensate, and then there goes the biceps tendinopathies on top of that. So then we strengthen specific muscles, right? Because sometimes you could have impingement of the subscapularis or supraspinatus. The subscapularis is the one underneath. That one can actually become really painful. That's the one that would do internal rotation, or when you squeeze something or push, they're all kind of working at the same time because they also do work like a steering wheel themselves. But the subscapularis will tend to be, the pecs tend to compensate for it. And so it's so challenging. Those are one of the hardest ones, is to teach internal rotation without the pecs firing. Yeah. Insanely challenging. So then it's also increasing specific strength while at the same time getting rid of that dysfunctional movement or improve the motor control. So yeah, that's kind of where we would address the initial, or the cause of it.
Yeah.
Rather. Did you want any other interventions, or do you guys, when there's tendinopathies, right? One of those, we were talking about degenerative type issues.
Yeah.
Calcifications in the tendons.
Yeah.
Tell us
a little
bit
of
about
those recently.
What you do. I know.
Yeah. So I mean, also just like going on, John, like posture is so critical. So like anybody, shoulder, neck, right? If we're not treating posture, similar to like any other dysfunction, right? Like if our core and glutes aren't strong, like we are not going to be walking correctly. We're not going to be using those muscles correctly. That can end up in hip pain, knee pain. So all about kind of going back to that root cause and like looking at our body and the analysis and seeing what's weak so that we can actually treat that, rather than just being like, yes, here's a pill or an injection and like, you're good to go. We got to make sure we're treating kind of the root cause so that we can prevent this from happening again. But yes, calcifications. So calcifications are like sort of like a misunderstood thing, but you can have calcifications that actually show up within the tendon themselves. So supraspinatus is again that most common tendon that is injured, that one on top. And sometimes after an injury or like just chronic overuse, you can get calcifications actually within the tendon itself, which is called calcific tendinosis or calcific tendinopathy. We sometimes start treatment the same exact way, with the whole course that we talked about already. And if it's just not getting better, we then actually go after the calcium. So something that I do in my office is I actually take a needle and I break up the calcium. So I use my ultrasound to kind of guide my needle into that area of the calcification because I can see it under the ultrasound. And I fenestrate, or I break it up, literally just like poking at it a lot while also injecting a little bit of numbing medication. And then it actually, you'll see the calcium. I can show you a picture literally from something I did today of, I had someone with calcific tendinosis. And so as you inject, some of that calcium will actually come back out into the syringe. So you'll see like little white stuff floating. And then with time, you know, the body should absorb the rest of that. But breaking that up really helps to start, you know, get that process moving. Aside from that procedure, there's also shockwave. So shockwave uses sound waves to help. It's similar to like what we use for kidney stones. So to kind of like break up scar tissue and also create an inflammatory response within the tendon or whatever area we're dealing with, to then stimulate healing in the area, which is cool because there's no needle. It kind of just feels like you're getting a jackhammer to whatever area. It's fairly loud for others that are nearby, but it's been working super well for kind of these chronic tendon issues that we're seeing.
Cool.
Yeah.
That goes along. So one of the things, so we were talking about postural things. I didn't mention spine mobility. And that kind of goes along with posture, right? Because if our spine, if each vertebra, you know, one is on top of the other and they have facet joints, they're the joints that they each, let's see, one more. So our facet joints are the joints that they each sort of articulate. They have two on each side. And so what happens, they're about at a 45-degree angle at our neck. So if we are sort of in a slump position, that's another one that you guys can try. Go back to your super fun slump position and notice what happens. How does it feel like? You don't have to do it. You've lived there for some time. You can say yes.
Yes.
Okay. You can sort of notice what happens. How can I move here? And it's not just the cervical spine. How does your jaw feel when you open it and you're slumped? How does it, if you rotate, if you try to move here, what is that like? But then now we're going to place that spine in the, you know, we're going to stack it up where it's meant to be and notice how much more and how much freer that is, how your jaw now can open differently, and how much your thoracic spine can move. So it's one of those Jenga pieces. And then you add, so that spine mobility will have people that, again, are our retirees that are now having all this extra time to go and enjoy life, that they're like, oh my God, I'm so stiff. And it's like, yeah, the shoulder pain is like, oh my God, you barely move through your thoracic spine because for 35 years you were sitting at a desk, not moving much of anything. So the spine mobility is super important as well. So with regards to our interventions, you know, you mentioned the shockwave and the needling.
Mm-hmm.
It was, what was the name
of the needling?
Yeah, do we just...
So barbotage. So the fancy name, or tenotomy.
Okay.
Yeah.
That's the procedure name.
Yeah.
So then we sort of look at, or injections, the shockwave, all those are interventions or passive. So we have the deep tissue laser, which is basically using light therapy. It's a class 4 laser that uses light therapy to speed up cellular metabolism and therefore speed up healing in your body. So you could have someone, and I've had good success with someone that did the shockwave, and they have really cool images. This was out of a chiropractor office, so they had the image right there, and he did it to himself. So he saw his awful calcification, like, oh my God. He was doing shockwave, and he was coming here. We were doing laser, and he did his before and after image. Yeah. It was literally like, where did it go? I had never seen anything like that to help it reabsorb so quickly. So that was pretty cool. So again, so more passive. Along the side of that, we would do soft tissue release. All these muscles that become that upper trap, You know, people forget that because they've been living in this position, oh, I'm going to lift. They end up lifting, and all these upper trap and levator scapula, they just get super tight, right? So we release it with different Graston instruments. You guys have all seen them before, but for purposes of the video, our set of Graston instruments. Okay, so different metal instruments to separate and release the soft tissue and the fascia, right? Then we would do spine mobilization too, some different techniques to the spine. Maybe sometimes the first rib can be another one that can get caught up in there and all that dysfunction through the shoulder blade. Joint mobilization. So if we have someone that's kind of like this and they come in just postural, they may need the back, the posterior or the back, the capsule in the back of the shoulder blade, or I'm sorry, in the back of the shoulder. So we talk of the shoulder is technically the joint between the humerus and the shoulder blade. But people think of the whole shoulder as the whole thing. But the true shoulder is just these two joints. This is the scapulothoracic joint, is the one between the shoulder blade and the ribs. So the humerus can get kind of stuck forward and sits forward. Another one that I have people, it's like, oh my God, and it just pinches so much. And then I'll go in and I'll push. Sometimes this sort of happen that the people will fall asleep like this, and that humerus gets kind of stuck forward. And because you go and do everything there, well, it never kind of kicks back. And just a little bit of mobilization of the humerus to just push it back. Oh my God, it's such a relief. Because why? We're opening up that subacromial space. At the same time, now all the tissue behind it of the shoulder capsule and the muscles, it's gotten sort of extra tight here and extra sort of tight if they've kept it for a while, or overstretched to a certain sense, and the rotator cuff doesn't have enough strength to hold it there. So it's doing movements in with some pressure here to teach the rotator cuff to get the strength now that they're in the right space. Yeah. We can talk about frozen shoulder.
Just like another comment.
Yeah, that's another one. You want to go?
Yeah.
You want to start with the frozen shoulder idea?
Yeah, so frozen shoulder is just another really common manifestation of shoulder pain that we see most common in females aged 40 to 60. That's kind of like the sweet spot for it. Underlying risk factors that can put people at increased risk: people with diabetes, people with thyroid issues, obviously females are at higher risk. And then most importantly, anytime somebody has had an injury, that puts them at risk, because if they've been immobilized for a little bit of time, then that obviously increases your risk. So essentially what happens is the capsule of the shoulder joint literally like stiffens up. And so there's 3 phases of frozen shoulder: the freezing phase, the frozen phase, and then the thawing out phase. If you don't do anything about this issue, it will resolve on its own, but can take an upwards of like 18 months, like 24 months. And this is like a fairly painful and very limiting issue that people don't typically want to deal with for that long. And so in the freezing phase, it's really painful. And what happens is, if somebody's had an injury, they obviously don't want to be moving that shoulder. So they kind of just like keep it close to them for a while. They really don't want to move it because it's just painful. That capsule starts stiffening up, and people are just like in severe pain. Once they start losing mobility little by little as they're not using it, as they get more into that frozen phase, literally they cannot move. And the important part is, like, a lot of times people can't move because it's painful. And so for me as a physician, or and John or Easton is seeing them, like, I can usually get people up if it's a rotator cuff issue or other issues that it's not limiting their mobility, but I can get them up. They just can't do it themselves because it's painful. With frozen shoulder, if I'm trying to get them above a certain spot, it just stops. Like,
I break sweats trying to get someone's humerus to move because it's just not.
Yeah. So it's what we call active and passive range of motion. So active meaning patient doing it, passive meaning physician or physical therapist is doing it, that is super limited, and you just hit a point that you're not getting any further. And when you're like, you have now developed frozen shoulder, and so now it's how do we fix this and kind of accelerate the process that will get better on its own eventually, but how can we make this more comfortable for you? And so one of those things, obviously, the patient needs to get moving, and that is kind of what got them into this issue in the first place, is they literally weren't moving it. And so really trying to stress range of motion and like really doing a lot of manual and getting them into therapy. Sometimes to accelerate that process and get them a little bit more comfortable, we can do an injection, and that injection I will do into the joint.
That can be really helpful
and that'll
to tolerate.
Yeah, and so that really gets people moving, because even with that numbing medication and a little bit of steroid, within 2 days, they're like, oh yeah, I have way less pain. And then we really try to like stress their range of motion in kind of all motions. So, above, doing that external rotation, which they lose a ton of, that internal rotation too. And this is like obviously really disabling, because they cannot do like anything. You can't externally rotate, you can't reach back behind you. So people are saying like, they can't go to the bathroom and wipe, right? Because they literally can't reach behind them. So your activities of daily living are getting, really impacted. And so doing an injection, and sometimes I put a little bit more volume in to really help to kind of extend the capsule, will help. And then really making sure that patient starts doing range of motion exercises and gets into PT, so that we can take advantage of the injection being in. So those are kind of the biggest things that we do. And then, you can talk about.
Yeah, so one of the things that I've been able to see, so oftentimes, oh yeah, it's frozen shoulder, send them on to PT. But there's such a difference, the true adhesive capsulitis, there's actual cellular changes that happen in that shoulder capsule, that the only way to really see it would be to take a little piece of it and look at under a microscope, right? Oftentimes I've also seen people that I'll move the shoulder and I get such a improvement. I was like, yeah, this isn't a true adhesive capsule. This is more of a stiff shoulder, right? The other thing is with adhesive capsulitis, it's a very typical pattern. It's external rotation, flexion, and abduction. Those are, it's in that order that you lose it. So it's pretty typical, and it'll just kind of get stuck.
Yeah,
it's pretty interesting. But yeah, every person that I've seen that we just sort of push, there are some that it's like, oh, just like, and I just want to just go get an injection. It'll make it so much easier on all of us. And I particularly like injections simply because it's local to the area. They don't have to take something that's systemic. And that's another one that for pain, the laser has really helped. Sometimes the other thing that I sort of want to touch base on with shoulder pain is that AC joint. And so this is more in older people where arthritis, time and gravity continue to do their thing, and posture. Sometimes the AC joint, the joint between the clavicle and the acromion process, also gets arthritic. Because yes, our shoulder moves, but the clavicle actually rotates. It does a pretty cool triplanar movement. And so that can also develop some arthritic changes. And so what are some of the, do you have any specific, so for example, I guess you have the ultrasound. Be like, is it a bursitis? Do I inject the bursa or the tendon?
Yeah.
Because to me, that I don't have those eyes, and it's like, oh.
Well, that's why it's.
Or is it the AC joint? Yeah. So you have to be.
That's why it's super helpful, and really differentiating when doing the physical exam, because again, like I said, in rotator cuff, biceps can be super painful, but if your rotator cuff signs and your bicep signs are both positive, it's usually the rotator cuff, and that biceps pain will improve if we kind of attack it from a rotator cuff standpoint, and then obviously like the therapy that does all the postural and the scapular stabilization. AC joint, they will point to like the top of their shoulder. And so if it's an acute injury, it's usually, we see this a ton in the winter because people skiing and snowboarding, they fall onto their shoulder like this, and so they'll get AC joint sprains. Sometimes they'll get like clavicle fractures, but that can hurt the AC joint. But otherwise, yeah, we see a lot of like arthritic ones. And sometimes people will try like injections into the bursa, they'll do, you know, joint injections, but they're pretty specific when you are talking about the AC joint and you touch that joint really in between those bones. And like, I have an ultrasound, so I'll put the ultrasound on it, and they're like, yes. And they'll literally like drop their shoulder as you touch it, because they're like, that is the pain. And so like, it's really important to ask, like, is this the exact pain you're experiencing, or is like that just hurt you? Because
Yes.
like, I have a fairly hard touch, and like, I'm trying to get into stuff.
They
and
look very pokey little fingers.
I know, and I like I literally touch really hard. But patients are like, no, that's fine. You just figure out what you're doing. And that injection, I mean, that should usually be done under ultrasound, because it's especially these arthritic ones, you have a lot of like bone spurs and joint space narrowing in an already very small joint. So getting a needle in to the right area can be challenging, even with an ultrasound. And so that's really helpful, and like, it cannot take a lot of fluid. So like, those injections for me are very small volume injections, whereas if I'm going into the joint, can obviously take a lot more. But those patients, like, and then they feel, because there's lidocaine and numbing medication in there, if that's really what's hurting them, they're like, yes, like that
Okay,
area. Yeah, so it's satisfying.
What are some of the medications that you inject into the rotator cuff? You
Yeah.
mentioned lidocaine, but that's part of it.
Yeah, so lidocaine is just numbing, so I use a local anesthetic pretty much as part of everything because it makes people feel better. Then I use cortisone, so usually Kenalog is the specific one that I use if I'm going into bursa or joint. If I'm ever, like, if somebody has a partial tear or, you know, anything like that, or chronic tendon changes, then I'll do something like PRP, if I'm going into the tendon itself. So PRP is platelet-rich plasma. You guys have probably heard it like with high-level athletes and like everyone's talking about these days. Essentially what that is, you come in, we draw your blood, and then we put it into a machine that spins it down and separates it into its separate components. So red blood cells, white blood cells, and platelets. Depending on the issue will depend on kind of what the makeup is that I use, and that's individualized per patient. Once we spin that down, we get a much smaller volume of very highly concentrated platelets. And platelets we know as, you know, they help clot, but they also have a lot of nutrients and growth factors. So I then inject that back into the area to help to stimulate healing, you know, and allow our body to kind of do the rest of it. So using our own body's natural healing, inject that back in without adding, you know, anything separate. So that's another cool thing that we can do. Think of anything else fun that I inject. That's like pretty much it.
Cool.
Yeah.
It makes a difference with different. So a number of my patients have come in with some of the concerns, like, oh, well, you know, Dr. Google said that I shouldn't do, is it okay if I keep injecting cortisone in the joint past a certain number? Because I've been going to this doctor, and this is gonna be my 5th injection in the past 3 years. And so tell us a little bit about that.
Yeah, yes, so too much cortisone, not a good thing. And so I really try to limit cortisone to really like people who are in like fairly severe pain, to get them out of that pain so they can start getting into rehab and optimizing, right? I'm not like, yes, you will come in every 3 months, this is what we're gonna do, this is your like life plan. It's never, cortisone is an anti-inflammatory, and when directed into a joint or into the bursa in a very like targeted fashion, is great for calming things down within the short time period. Really, every study that's been out there shows no long-term improvement, but it really will help to improve that pain quickly, to help get you moving, get you stronger, to give you longer lasting relief and kind of treat the root cause. If you do too many cortisones over time, especially into a joint and definitely like near a tendon, it will start to actually like degrade the joint, and it can really start to hurt the cartilage. And wear it down, which is obviously not what we are looking for. And so again, sparingly they are fine, but you know, cortisone every 3 months, and certainly more frequently than that, is, you know, something I definitely avoid doing, and I will tell patients that. But like, if they are in severe pain, I do think it's a great option to get them out of that, but knowing like, yes, this is, you know, we do not want to be doing too many of these because it can hurt the joint. If you do just 1 or, you know, 2 a year, there's no issue. Like, there's very minimal, and like a lot of patients are worried about that too, but it's really just the over time doing it consistently
In the same place.
in the same place can have negative effects on the joint, on the cartilage. And definitely if you put it near a tendon, and so like if you're doing injections that are not guided and you get near a tendon, whether that's, you know, the rotator cuff, it can weaken the tendon and increase risk of rupture. So that is why I try to do everything guided so that I know where I'm going.
Definitely sounds like a plus.
Yes.
So to your point of like, you know, back to your issue of like, oh, it hurts when I'm on my side, it's possible you could have a little bursitis because it was just sort of like overstretched in a position where it was just compressed. It's possible you can have a little tendonitis because the tendon got inflamed a little bit because, again, that little subacromial space and that little tendon got inflamed. Could it be some AC joint? Probably not with your age, my age. I'm coming up to 47. I actually was really sick recently and I slept 12 hours straight. I probably didn't move and I woke up and I'm like, Easton, please move my AC joint because it was all stuck. It was awful. So probably not your case. But so one of the things that anybody can start right away is watch your posture, right? So when you're dealing with posture and you'll say, okay, sit up nice and tall, people will do this. And it's like, it's not necessarily about moving through your thoracic spine. It's more about bringing your shoulder blades back ever so slightly, right? So it's not just bringing them back like that, not really. It's just that small change. So if you're looking from the side, so if you have someone take your picture from the side, you should be able to, ooh, can I use you?
Yeah.
Cool. I'm gonna have you over here.
Like
Just
right?
sort of face, just, yeah. I'm gonna take care this way. We should be able to see the ear, shoulder, and hip, also in seated position. Have that be a nice lined up position. I've never seen Sassy, but she's probably in a good position.
Probably not aligned.
Yeah, no, she's probably in a good position. So if you notice that, you know, do a little slouch position. And someone takes a picture and you can draw a line, oh, my ear's in front of my shoulder, right? That can also affect, and we can see sort of like this part where the shoulder blades come forward. This then gets that humerus forward that then can start that impingement here. Oh, well, come up nice and tall again. I can sort of put my hands here and here. Huh. Sassy's shoulder's a little bit anteriorly glided anteriorly.
It's very mobile.
Yeah. Cool. Face the other way. Do you see the difference where these are? And it looks a little bit more central. Oh, are you right-handed by any chance? Yeah. So just a little bit of anterior. So in this case, now we go back. Okay. In this case, let me have you face away from the camera. Mm-hmm. So you can see here, they're actually pretty even. We can't let the little tag fool us. Now I'm gonna have you can sort of see, I can see how the scapula is kind of ever so slightly tilted, just postural, it's just normal. Bring your arms all the way overhead and down. Good. So by putting my hands here, I can really feel that they're actually moving nice and together. Some people do this, and then they do all kinds of weird stuff. And then bring your arms all the way up again. And then we can also see that there's, given where that scapula is, this also looks a little different than this one. Do you guys see?
Mm-hmm.
Yeah? And so, again, it's just, and come down. Thank you.
Okay.
It doesn't mean, do you have any shoulder issues here and there?
Yes.
Oh, okay.
I mean, it's not terrible, but
Yeah,
yeah.
because the other part is that you can have these movement dysfunctions and be totally fine.
Most of the time I am.
Yeah.
Mm-hmm.
And be totally fine. And so, and so in maybe, you know, as you get closer to time keeps pulling and that little tendon keeps doing stuff, but maybe not. You could be some of those lucky people out there that they're totally fine. Like, oh my God, I bet you that's like super arthritic and I'm fine, I don't have any issues. So then don't do anything. But work on the posture because that's gonna be one day I have people like, that's why my mother told me to do my posture all the time.
Yeah.
But again, some of these are just normal
Yeah.
things because of our dominance. So
Yeah.
the best thing that anyone with shoulder issues can do, improve your posture, engage your core. I actually think of the shoulder blade muscles and the hip muscles as part of the core.
Yeah.
I like to say that without that, then what? You're gonna have a torso like hopping around? No. You need to have, why is the core there? To stabilize our extremities.
Yeah.
So you might as well use the, yes. So scapular muscles and hip muscles are part of Jana's world tour.
Stability.
Yes, and stability of the core. So posture, and what was my other one? Oh, stability, right? So just keep that engaged. So if you're gonna go reach, like engage the shoulder blades. An easy one would be, imagine sort of like the letter D, right? We don't really wanna go up, but if you need to go up to just sort of test a little bit and just sort of bring the shoulder blades back so that serratus gets a little bit fired up and turned on, because oftentimes people have a really hard time, like, how do I engage my serratus? And it's like, and it's not. So sort of like the up and back, there I am. So if you're sitting down, I don't know how far that camera is, but you're sitting down at a desk, you don't want to do this. Every so often, take a moment to go up, a little backwards, and feel that. Same thing driving, and you've got sort of positions that puts you there. And don't ignore it. Do something now. So, one of the things that, thank you guys for coming, I appreciate it, that there are so many issues that could be within the shoulder that a good exam is really where you can be specific. Now, some of you could just, like Christina, could just like, oh, posture and strength. That's going to take away what's irritating it, and then you get better because you're nice and young and you moved along. You can do a little bit of ice if you want, but great. But if that doesn't take care of it, then seek some help. Did you want to do the same thing that we did with the knee one?
Sure.
Good. So one of the things that, because you guys, sure, yeah. Oh wait, is this still, okay, good. For those of you that are still watching this video, because I don't know if it's live still, okay. Either now or within the next week or so, we're gonna offer, that way so you do something about your shoulder, offer where you can do a visit with Dr. Sassy for an evaluation and address whatever it needs to be, and then three physical therapy visits. You remember those numbers? So our numbers, yeah, so the evaluation for Dr. Sassy would be $250, and then that saves you $50 from the original exam. And then for physical therapy, it would be $175 for 3 visits. Because we want you to evaluate you, that is a 90-minute evaluation. And then, or I'm sorry, a 60-minute evaluation, and then 2 follow-ups, where then we give you some homework, we treat it, and then you do it, make sure you do it again, because again, the trick is to deal with the cause. And so those would be $175, which then each would give you a savings of $75 from the flat $250 fee. So that's for those of you, so that the idea is that you would see Dr. Sassy, then you would come and work with us. Cool.
Anybody have questions?
Any specific questions or that you can think of?
I think I do. So I've been having neck issues and shoulder issues all together, and I went to see a neurologist, and they said that it's it's cervical rib something fancy words. Yeah, there you go. And it's like it's a pinched nerve. Just don't do anything to it. Like don't go see a chiropractor or whatever. And that made sense. But don't lift or don't do anything about it basically. So could that ever be cured? Like, could an impinged nerve be cured by just posture correction and just strength? Okay.
Yeah, and I mean, were you having like numbness tingling down
No, it just radiated down around the scapula.
in your traps and stuff?
Yeah.
Yeah. Yeah, so probably a lot could be posture, and like also what happens is like when we do have pain or poor posture, we're often like holding our traps like higher up, right? And like this happens also when we're super stressed. So people will notice when they're stressed, right? Like we are holding our shoulders up like this without even noticing, and then we're wondering why this is like so fired up, we're getting headaches, and like it all just kind of radiates up. And like as soon as I do a trap release or kind of work on that area, you know, manually as they do in therapy here, and work on posture, that can be huge. I mean, sometimes you might need something else too, depending on like your symptoms and the exact cause, but I like truly think that non-operatively can really get most things like back to where you want to be and better. Yeah, but yes, yeah, I mean, totally depending on what's going on, I try to have people moving and like doing stuff. Because especially tendon issues, like tendons really like to move to get better. They just have to be moved in a certain way, but I don't love having people just like rest and do nothing.
Right. Makes sense.
Yeah.
Thank you.
Cool. So, but you work with the full body, right?
I do.
So if there's ever any other
Full body,
full body issues.
head, shoulders, knees, and toes, and more. I do the lifestyle piece too.
I just had so my kids went to nature school for preschool, and
Yeah.
they had a song for themselves to check for ticks.
Oh, smart.
Head behind the ears and in your armpits.
That's
Behind the knees, check for ticks and fleas. Head behind the ears.
That's very
Armpits and
impressive
belly
that
buttons.
you remember it.
The things that stay in here are amazing.
That's pretty good.
Don't ask me names.
Yeah.
Cool.
Awesome.
Later.